Good evening, everyone. Let's start with the case. An unsolicited guest. Coming to the case, a 53-year-old female, non-case of systemic hypertension, hypothyroidism, type 2 diabetes mellitus, presented with complaints of headache since 1 week, lower abdominal pain since 1 week, and vomiting since 3 days. History of presenting illness. Patient was apparently well 1 week back when she developed headache, which was sudden in onset, gradually progressive, persistent, bifrontal, associated with fatigue and disturbed sleep. She also had an abdominal pain, which was insidious in onset, gradually progressive, diffuse all over the abdomen, more over the lower abdomen, and catchy in type. History of multiple episodes of vomiting, non-projectile, non-blood stained. She was evaluated in another hospital 1 week back when the symptoms started and was treated as a case of acute gastroenteritis, AKI, sinusitis with injection piptas, and she was discharged on tab moxiclav. Her headache and vomiting persisted. Lower abdominal pain subsided and these symptoms persisted. Hence, she consulted our hospital for further management, evaluation and management. There was no history of fever, nasal catarrh or cough, no history of dysuria, change in urine frequency, no history of GTCS or altered sensorium, no history of blurring of vision or double vision at the time of presentation, no history of facial drooping or limb weakness, no history of any band-like sensation over the head, or no history of any fall or trauma to the head. Coming to the past history, no history of other illnesses like seizure, bronchial asthma, tuberculosis, CVA or CAD. After admission, immediately after the admission, the patient started to have complaining of blurring of the vision, especially in the right eye more than the left eye, with double vision in the right eye. So, we went into the clinical examination. She was conscious, well-oriented to time, place and person. In the vitals, her BP was on the higher side, 180-100 mmHg and equal in both arms, and pulse rate was 58 beats per minute. And pallor-icterus, clubbing, cyanosis, lymphadenopathy were absent. Coming to the CNS examination, in CNS examination, we got terminal neck stiffness present. Kernicks was negative. And on examination of the extraocular movements, the abduction of the right eye was restricted. And the patient was having more appreciation of the double vision on looking to the distant side and looking into the right side. And CVS, respiratory system and abdomen were within normal limits. So summary, so we have a patient non-case of systemic hypertension, hypothyroidism, presented with complaints of headache, vomiting, later developing blurring of vision and diplopia. And on examination, she was having neck stiffness and right lateral rectus palsy.
Yes, it is almost a straightforward case, I think. What is your opinion in this case from the audience at this point of time?
You need to rule out an intercalated lesion because of lateral rectus palsy.
Yes,
Yeah.
yes, that is one possibility. But we have to account for the fever, body ache, headache, and the other constitutional symptoms also.
Meningitis.
Meningitis is a strong possibility. Encephalitis, very good. Encephalitis is another possibility. Yeah, with ketosis. Yeah, diffuse abdominal. Yes, that is a very good diagnosis or a differential diagnosis. Then, anything more? This patient? Yeah. Yeah, agreed, sir.
And the way the patient presented with a gastroenteritis, which was a apparent diagnosis at the previous hospital, sudden onset of headache and vomiting. Vomiting persisted. My friend, on examination, there was neck rigidity. Definitely a possibility of acute viral meningitis is a possibility.
Agreed.
Because sensorium was normal, I do not consider a possibility of encephalitis.
Yeah, very good. Usually in encephalitis, sensorium will get disturbed. That is a differentiating feature in meningitis versus encephalitis. And neck stiffness also may not be so prominent in encephalitis. Maybe there, but not so prominent as in meningitis. Okay. Why you said diplopia or on looking to distant vision? What is the importance of that? She mentioned. Put the previous slide. Take the previous slide. Right eye patient having double vision on distant vision and looking to right side. What about near vision?
It mostly diplopia is because of intracranial hypertension, and the first feature, mostly it says that in the first feature of raised intracranial hypertension will be double vision on looking to the distant side. Later it will be double vision on both near, looking to near and distant, but initial symptom will be double vision on looking to the distant side.
Okay, sir. Very good. Then the DNB and MD students also should participate. Yes, any other? So, viral meningitis, space occupying lesion, pseudotumor cerebrae, then meningitis with encephalitis. These are any more possibilities? Started with loose motion, lasted for 3-4 days, followed by vomiting, fever, headache, and neck stiffness. Yes, is it?
No, sir, it was semi-solid in type with no blood or bile stain.
You are thinking for?
Amoebic.
Very good.
Yes.
Amoebic is another possibility. Anybody is thinking in favor of an entry fever producing meningism? Is it possible? Fever is there.
No history of fever.
Yeah.
Was there a history of continuous fever?
No. Yeah, usually meningism, where neck stiffness
Meningitis.
may not be seen. That is one important peculiarity. The usual favorite question is there, what is meant by coma vigil?
The lateral rectus palsy, I think it's just a sympathizer because it has one of the large intracranial cause. Any case of intracranial hypertension you may have.
Any condition where there is an increase in the intracranial pressure, including IIH, because of the long course of the nerve in the brain, lateral rectus palsy, resistant nerve palsy is very common. Largest course is having fourth nerve.
Yeah.
Second is the system.
Like it's just a sympathizer problem.
Okay, with these possibilities, we will proceed further. Okay.
So, so the differential diagnosis were considered like vascular headache, meningitis, hypertensive emergency, idiopathic intracranial hypertension, intracranial bleed, or space occupying lesion. So,
Why you consider vascular headache? Can you explain it?
like in symptoms, like the patient was having headache, vomiting. There was no photophobia or phonophobia, but the migraines, headache can be, there can be cervical pain also.
But lateral rectus palsy, how will you explain with a vascular headache?
That cannot be explained, but
Yes, it can be explained. Post-migrainous palsy.
One
Even-
suggestion: when you write differential diagnosis, please write it in the order of prioritization, most likely. And so here, vascular headache, if at all you're thinking about it, it's not the first one. It's not the first one.
You
have
should note that
meningitis.
point also. Okay, proceed.
so coming to the routine blood investigation, the routine blood investigation showed leukocytosis with elevated eosinophils. That means there was peripheral eosinophilia showing 25% of eosinophils. And the peripheral smear was done, which was also showing eosinophilia with absolute eosinophilic count of 6,212. The other routine blood investigation like liver parameters, renal parameters, serum electrolytes, urine routine, and stool routine was within normal limits. ECG was showing sinus bradycardia. And an ophthalmology consultation was done because she was having.
Why sinus bradycardia? DNB students? Yeah. Because of raised intracranial tension. Great. Okay.
So, planned for an ophthalmology consultation for fundus examination because she was complaining of diplopia. So, the fundus was within normal limit.
Physicians should look at the fundus first. Don't call the ophthalmologist. I remember one MD student writing a surgical consultation. Sir, kindly come and do PR for this patient. Please don't do that.
Yeah, but the custom in our hospital, after I joined in DC hospital, they want documentation of fundus examination. So they insist to send for ophthalmic consultation for fundus examination.
Fundus examination.
Yeah. And we insisted to buy ophthalmoscope of their own, and they have to see all patients. They will write, but finally, for documentation purpose, we will send to ophthalmologist. Otherwise, if something happens, they will tell, we have simply written it.
No.
Only 8 years. Yeah.
So retinorenal, usually you would have expected some fundal pain.
Yeah, that is true. In a diabetic patient who develops renal involvement with a raised serum creatinine, will definitely have some fundal changes. But fortunately, this patient is not having that. Okay.
And there was a restriction of the right eye abduction. So, how to proceed? So, the patient is having headache, vomiting and blurring of vision and diplopia. Examination showing neck stiffness and right lateral rectus palsy. So, the plan was to proceed with MRI brain and CSF studies. So, the MRI brain was taken, which was showing leptomeningeal enhancement. That means after the post-contrast, there was enhancement of the sulci of the brain. And this is the video showing the throughout the brain, there was leptomeningeal enhancement. That the sulci can be seen as white color clearly after the contrast.
So, leptomeningitis is confirmed.
So, we proceeded with LP study, so which showed opening pressure of 25 centimeter, slightly elevated, and CSF was showing increase in total count, that is 598, and the CSF was also having increased eosinophils. Lymphocytes were 73% and eosinophils were 25%. The other things like ADA was negative in the CSF, and CSF glucose by blood glucose ratio was also normal.
So, this finding is suggestive of what?
These findings are suggestive of either it can be an eosinophilic prominent meningitis, or it can be fungal meningitis also. But usually in fungal meningitis, the CSF glucose by blood glucose will be low, but it is not an absolute thing in all fungal meningitis. Tubercular can be ruled out by seeing the other parameters, and also bacterial is ruled out by seeing the total count and also the neutrophils.
Here the unusual finding we noticed is the rise in the eosinophil count in CSF also. Peripheral blood it is there. Absolute eosinophil count is very high, and in CSF eosinophil count is also around 25, very high. Right.
So, the other investigations of the CSF like gram stain showed occasional pus cells with no organism. Fungal staining and inthinic staining was negative, and CSF culture was also noted to be sterile. And the meningitis encephalitis panel came to be negative. So, a diagnosis of eosinophilic meningitis was considered because the diagnostic criteria for eosinophilic meningitis is more than 10 eosinophils in millimeter cube of CSF, or eosinophils accounting for more than 10% of the CSF leukocytes. So here it was 25. So we can consider this as a case of eosinophilic meningitis. So immediately after the diagnosis, the treatment for eosinophilic meningitis was initiated. That was steroid therapy with injection dexamethasone 4 mg IV Q6H. But the question was, what will be the cause of eosinophilic meningitis in this particular patient? In search of the cause, we were again going into considering the causes of eosinophilic meningitis. We took the history again in detail. So the family
I'd like to
history.
interrupt. Actually, I'd like to interrupt now.
Yes.
Actually, she had already told that at this point, I was interested in knowing the history, especially two things which I into which part of Kerala does she comes, about her food habits, this patient.
Yes. From which part of the Kerala she is coming? Evadaya?
She's from Aluva, sir.
From our area, we see that. That's what I specifically asked.
Yeah.
Udumbu.
Your place? Alla, Kolanjeri, what you are seeing?
Udumbu.
Udumbന്റെ ഇറച്ചി കഴിച്ചു.
Yeah, they
That is there. In
Monitor lizard, no?
Eosinophilic meningitis.
yes.
Monitor lizard, they eat that
They eat it raw.
and they can get this.
Yeah, it is true. Actually, two published cases of case series of eosinophilic meningitis from Kerala are in both the case series. They have found that consumption of monitor lizard to be the cause of eosinophilic meningitis because it is consumed in many parts because of our state due to its so-called aphrodisiac properties. Yeah, that is the thing. And the latest case series they found snails again to be one of the causes for eosinophilic meningitis. Snails have well established studies are there in children where snails contaminating food causing eosinophilic meningitis. We'll go further.
So the history was in detail taken, and that time she revealed that her husband, with the symptoms of giddiness, headache, was admitted under neuromedicine on the same day. So what about his findings and what about his investigation reports? So comparison of the blood investigation and CSF investigation of both the patients. Patient A is the wife and patient B is the husband. Both of them were having peripheral eosinophilia, one having 25%, other having 32%. And CSF also, both were having increased eosinophil count. The wife was having again 25% and the husband was having 84% eosinophils in the CSF. So the MRI brain of the husband was taken and it was showing leptomeningeal enhancement and other features like carotid artery stenosis was there and other chronic infarcts were there. So the patient B also met the criteria for eosinophilic meningitis with 32% of eosinophils. So now we took why two members in a family developing eosinophilic meningitis. Going back to their history, any history of recent intake of food like snail, slug, seafoods, frog or snake was taken. Both of them could recollect intake of crab 2 to 3 weeks back these symptoms. Can it be the cause? That was the first question. So the most common organism to cause eosinophilic meningitis is Angiostrongylus cantonensis. So we had the keep sample of the CSF of the patient, which was sent to Amrita Institute of Medical Sciences for PCR of Angiostrongylus cantonensis. And this was the reports of both the patient. One is the husband and the wife. Both of their CSF keep samples came to be positive, PCR positive for Angiostrongylus cantonensis. So the final diagnosis was made, that is eosinophilic meningitis caused by Angiostrongylus cantonensis, and the mode of infection most probably the crab intake. And the treatment was given. Patient was started on steroid IV given for 7 days and followed by oral steroids. Once the organism was identified, she was also started on tab albendazole 400 mg BD and it was given for 21 days. So response to the treatment of the patient. Headache improved within 3 to 4 days of steroid therapy. Blurring of vision and diplopia also started to improve after a week of treatment. And follow-up MRI, this was the follow-up MRI which showed she was symptomatically better also, and the MRI showed that previously noted hyperintensity in the sulcal spaces has been resolved. That is, the leptomeningeal enhancement is resolving. So coming to eosinophilic meningitis.
Just a minute. After seeing the first patient and knowing that her husband is admitted with a similar problem, and when you see those counts with very high eosinophils, what was the need for an MRI for him?
No, for him, MRI was taken in the emergency department itself when he presented with giddiness and syncope. So he was admitted under neuromedicine because he had leptomeningeal enhancement also, and the ICS stenosis was there.
So you mean to say that the second patient was actually the first patient?
No, both of
He
them.
came first and got admitted in neurology before the wife came. Is that correct? Wife first admitted. So that's the question. If you have the typical presentation of the lady and the counts, I don't know whether that MRI could have been avoided.
We are not the persons to see the patient for the first
And
time.
then 2 repeat MRIs.
Patient.
Where are we going these days?
Yeah, patient is first seen in the emergency department. They are not aware of such things. So once they saw a patient with a giddiness, vomiting, with a severe headache and other things.
Yeah, you have the luxury of doing 4 MRIs and 2 for follow-up. Anyway, nice.
Okay.
For a documentation sake, as Dr. Jill said correctly, that is okay. But then older physicians may keep cost in mind. And ultimately, the treatment was just albendazole and steroids. Anyway, it's
the
okay.
only thing is
To prove.
albendazole should not be started before starting steroids. What happens is the same hexamer reaction will occur, and the patient suddenly develop anaphylaxis, and we will lose the patient. So steroid is the first thing to start. Only after starting steroid for 1 day, you can add albendazole. So that is the thing I like to mention in this time. Don't be so aggressive in starting with the albendazole, because after seeing this, first we actually thought it is a fungal meningitis. Second possibility we also considered is the amoebic meningitis, which is very common nowadays. Few cases were reported. Yeah. Especially those people who are taking bath from the polluted ponds. Because in this rainy season also.
Coming to the life cycle,
just for the confirmation, husband's symptom was more severe, I think.
yes.
And the MRI showed an acute infarct also.
Yes.
That is why directly the emergency physician kept a consultation with neurologist, and neurology admitted from the casualty itself. Later on in evaluation, they found out both are same.
Okay. Okay. Any more comments? You want to add anything more?
No, sir. Antibiotic was not initiated.
We suspected eosinophilic meningitis because the patient had peripheral eosinophilia initially. So we didn't start any antibiotic in the initial stage. Went on with the LP and started steroid only.
Okay, കഴിഞ്ഞല്ലേ? മതി. Okay, doctor.
Thank you.
Thank you.